Baru 99 orang ya.
Masih sedikit ya, mau diobrakan berapa dikit dulu.
Okay, thank you. Distinguished guests, respected hospital directors, professors, colleagues, and friends from all across the globe. I see friends from Turkey, from India, from Malaysia, from Korea, from Taiwan, and many more. Good day and welcome. It's a truly an honor and a great pleasure to welcome you all to our 8th International Patient Center Care webinar, joint organized by CARS, PCCI, and ASQA. We are deeply grateful for your presence and continued commitment to advancing patient-centered care worldwide. Today's webinar carries a very important and timely theme, PCC in the world, global perspective of PCC implementation. The topic reflects our shared vision to learn from each other, to bridge diverse experience, and strengthen the global movement towards care and truly places patient, family, and communities at the center of the health system. We are especially privileged to welcome our distinguished speaker, Mr. Peter Lachman, a highly respected international health leader and a global advocate for quality, safety, and patient-centered care. Mr. Lachman's extensive experience and global insight have inspired healthcare leaders and organizations all around the world, and it's a great honor for us to learn directly from his expertise today. We sincerely thank Mr. Lachman for generosity, sharing knowledge, experience, and vision with us in this very important forum. I would also like to extend our heartfelt appreciation to all hospital directors, professors, healthcare leaders, practitioners, research colleagues who have joined us from many countries around the world. Your participation across a shared dedication to learning, collaboration, and continuous improvement in healthcare. We do hope that today's discussion will be enriched, inspiring, and practical, strengthening our collective efforts to implement patient-centered care in diverse health systems around the world. Once again, welcome to this webinar. We wish everybody a meaningful and engaging session. Thank you. We will start the meeting with a prayer from Dr. Johnny.
Okay, thank you, Dr. Hani. Dear respected colleagues, friends, and participants, before we begin, please allow me to offer this opening prayer in the Islamic tradition. We fully respect the diversity of faith among us, and we invite everyone to join in this moment of reflection, each in their own way and according to their own belief. Let us pray. Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful. O Allah, the source of all knowledge and wisdom, we thank you for this opportunity together with spiritually from across the globe. We ask for your guidance and blessing as we begin this important webinar, organized in the spirit of collaboration between the Patient-Centered Care Institute, the Hospital Accreditation Commission of Indonesia, the Asia Society for Quality in Healthcare, and with the valued support of experts from the International Society for Quality in Healthcare. Grant us clarity of mind, sincerity of heart, and strength of purpose. Bless us speakers, facilitator, and participants with meaningful insight and fruitful discussions. Help us to learn from one another, to share knowledge that bring healing, dignity, and compassion to patients everywhere. May this event contribute to the advancement of safe, quality, and patient-centered healthcare, not only in our respective countries but around the world. Forgive us our shortcoming and accept our humble effort. May peace, mercy, and blessing be upon us all. Amen. Thank you, Dr. Hani.
Thank you, Dr. Johnny. Now, we ask Dr. Sutoto, our head executive, to make an opening speech. Thank you.
Thank you very much, Dr. Hani. Assalamualaikum warahmatullahi wabarakatuh. Distinguished speaker, Dr. Peter Lahman, respected healthcare leader, healthcare professional, academic, and also participant from around the world. It is my great pleasure to welcome you to this international webinar entitled Patient-Centered Care in the World, Global Perspective on Patient-Centered Care. Healthcare is rapidly evolving through digital transformation, artificial intelligence, and innovative technologies. However, one principle remains unchanged. The patient must remain at the center of everything we do. Patient-centered care is more than a strategy or an accreditation requirement. It is a commitment to respecting patient values, listening to their voices, involving them in the decision, and delivering care that is safe, effective, compassionate, and respectful. Today, we are privileged to learn from Dr. Peter Lahman of Ireland, whose experience and expertise in healthcare quality and patient-centered care will provide valuable global insight for all of us. On behalf of CARS, I would like to express our sincere appreciation and gratitude for his willingness to share his knowledge and experience. I encourage all participants to engage actively in today's discussion and take inspiration from international best practices that can help us create healthcare system that are safer, cleaner, and truly centered on patient. Thank you for joining us, and I wish you an inspiring and productive session. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi. Thank you very much, Dr. Sutoto. Now we are going to go to the point. Please put Dr. Peter Lahman's curriculum vitae. Yeah. Curriculum vitae? Is it prepared? Thank you very much. And dear Dr. Peter Lahman, please have your time. Thank you.
Are we ready to go?
Yes.
Okay, I'm just going to share my screen, share sound. Okay, you can see the screen?
Yes, very good. The sound is also
Okay, that's good. Hello, everyone. Thank you so much for inviting me. Before I start, to my good friends all across in Asia, in Indonesia and Malaysia, I remember well my first visit to Malaysia for the Malaysian friends when we went to the conference in 2017. It's 9 years ago. It's hard to believe how long it goes. And in Japan, it was 10 years ago. Japan was 2016. Time flies. But I just want to draw attention to my backdrop, which is for the World Patient Safety Day themes, which I'm not speaking about today. Actually, I should add something to my presentation, which I will do somehow later on. For the first goal, which is about engaging parents and families. I hadn't thought about doing that, so I will open up another presentation straight after this to show you those goals, the first goal of engaging patients and families. And I'll end on that. Just reminded me to do that right now. But this is a year of the World Patient Safety Day for children and young and neonates. And I was fortunate to help write this. And the first one is to engage parents and families in patient safety. So what I'll do is I will just, if you bear for me 1 second, I'm going to stop sharing my screen. And I'm going to open that goal because I think that's very important that we do that. So if I stop sharing my screen just for 1 second and open another presentation, because when I'm sharing the screen, I can do that. So PowerPoint, escape. So I'm just going to open up another presentation to show you the file open recent World Patient Safety Day. More. I just want to open one more and then we can show you where I'm going to start from. Just have to open one more and then I'll get you. Sorry for the delay because I suddenly thought that I should open this one and none of them can open, so I have to go there. Desktop.
Is it the slide that you sent me?
No. This is an extra slide. Okay. So I'm starting with this slide today because you can see the slide.
Yes. Good.
Engaging children, parents, and young families. I'm starting with a slide because it's the World Patient Safety Day theme for the year. And as you can see from this slide, we have a number of themes based on human factors that are very important when you engage in patient safety. And I encourage all of you in the audience to download the World Patient Safety Goals and an advert to join us next Thursday afternoon at 1400 CET. So it's actually half an hour after our start time now. Oh no, it's now it's be 13, so it's 1400 Geneva time. And yeah, you can see the very important thing that I'm going to talk about in the rest of the talk. But if we are going to talk about person-centered care, it doesn't just happen. You have to work on it. So you can see you have to train healthcare workers' engagement. You have to promote this. You have to involve parents, patients in hospital committees. You have to involve parents and children in decisions, take their views. You have to have a number of tools that you can use. And more importantly, you have to measure your outcomes on patient safety and quality using PREMS and PROMs, patient safety report, patient family reported outcomes, patient and family reported experience. And these are high level, so I'd urge you to go into the actual document. And I just reminded you because my backdrop is just for this year is these goals. So this is what I'm going to be talking about today, but at a different level. But I thought I'd better bring your attention to the World Patient Safety Goals for this year. And as you can see, engaging people, the people who come to have care, that's the children, the parents and families, must be part of the solution of delivering care. And we at the WHO thought that this is goal number one. And every goal, the other goals are in infections and diagnosis and medication safety and neonatal safety, are all based on the foundation that you engage children, parents, and families. So now I go back to my original presentation, which is over here. So that wasn't too difficult. And now I'm going to talk about person-centered care in the world and global perspectives. So, Henny, you can still see the presentation.
Yeah.
Hello?
Yes.
Yeah. Okay.
Yes.
Yes.
Because I can't see you. I can't see you anywhere.
Yep.
Okay. So for some reason, I've lost you all. So I want you to imagine. Okay.
Yes.
Now I want everyone to imagine. Everyone on the call.
Yeah.
Imagine. What I want you to imagine and write in the text box. What is perfect care?
Perfect care. Yeah.
What is perfect care? I want you to all imagine what perfect care would be. What would perfect care be? So imagine
Yeah.
perfect care. What would it be? And I'm stopping the share to be able to see you all. So I want to watch this, must go in the text box. This is activity time for the 200 people. So I'd like to see 200 comments of imagination. What would perfect care be? And you can write it in whichever language you want.
At the chat, yeah. Please,
Yeah, in the chat.
friends, please put your comments. What's what's the perfect care?
In
And
any language.
Any language.
Any language that you like. Hani will translate if he wants to translate for me because
Yeah.
I'm watching it.
Yes.
So Nico says humanized care. Thanks, Nico. You are leading me to my talk.
Thank you.
Okay. So Michael says perfect care does not exist and is not achievable. However, Michael, I'm going to challenge you. Would you like it a non-achievable care or would you like perfect care for yourself? What is perfect care? That's great because this is very important because perfect care is difficult. It's a difficult concept. We always talk about pursuing perfection. And I'm going to show you what you have to pursue in the talk. Democratization of patient care from Hani. Hani, are there any others that are not in English that you can translate for me?
Yeah.
Yeah.
Oh no, it's
Ah.
that sorry, it's off cam because the signal is not very good. From
Okay.
Dr. Johnny, it's a quick,
Yeah.
responsive care.
Responsive.
Yeah, Michael says you'd be disappointed all the time. Well, Michael, we're trying to make that less difficult right now. Humanize humans. And I like listening to patients, involving them in decisions, providing high quality care, dignity, community, trust. I could end the talk now because now you know what perfect care is. Clara, patients know what's happening to them. They get the right treatment and their own opinions are heard. Care with respect from the heart of healthcare provider. Humanize the patient safety perspective. Can you see as we go in the chat, we've all got our concepts of what perfect care would be for us. What perfect care would be for a member of our family. a perfect care meaning for our partners, our husbands, our wives, our children. We want perfect care. But perfect care, as Michael has said, is very difficult to achieve. And here Hannah says perfect care when the child is satisfied with the care that we give. But often patients are satisfied with imperfect care because they don't know that it's imperfect.
Yeah.
So it's a very difficult one. It's a trick question I've asked you, perfect care.
Yeah.
So it's
Yeah,
very
yeah.
difficult. So let me go back to the talk. And what we'll do is I love Laverne's given much. As I said to you, I could read these all or the whole session, but I wanted to engage you right at the beginning. And now I'm going to share again to see how we're going. So now share. I must put my sound on. Share. Okay, now it's working because I can see you all. Okay, so let's get on. What perfect care could be. And one of you, I think it was someone said, it was Michael, I'm not sure, or no, it wasn't Michael. It was someone said it's about humanization of healthcare.
Dr. Nico.
Dr. Nico. Dr. Nico said humanization of healthcare. Dr. Nico, do you know what did you want to explain what humanization's about?
It's personalized care.
Yeah, personalized care. Changing people from patients and disease back to people.
Yeah.
So they are not someone who has a disease.
Yes.
They're someone who has a family, a hobby, a dog, a cat, a religion, a community, and also they so happen to have a disease.
Yeah.
So it's really humanization, and that's the key thing. So this talk's going to be more about the humanization of healthcare. And why must we do this? Now, I'm quite old because in 1974, I was in first year medicine. And I already done a bachelor's of arts degree, so you can see I'm giving my age away. And this book came out called Medical Nemesis by Ivan Illich.
Yeah.
And Ivan Illich was an interesting person. He was a Catholic priest at one stage, a philosopher, a teacher, and he wrote very, very controversial books. And this is the one that came out called Medical Nemesis. And what he said was that we in healthcare create clinical iatrogenesis. That means social iatrogenesis and cultural iatrogenesis. We harm people through unnecessary treatments, side effects. We medicalize life and death, and we undermine the traditional ways of dealing with this suffering and pain. And when we were medical students, we were told this is a book we shouldn't read. Of course, we read it. And what he's saying here is what we're trying to do. We're trying to change this back, because what we did in the 20th century with the scientific advances in medicine, we created interventions that harmed people. We medicalized life and death, and medical institutions controlled them instead of the community. And there were often very good traditional ways of treating that we undermine because they're we call them alternative interventions now. So I remember as a medical student in 1976, after this book, I read the book, then I organized a conference at my medical school with traditional healers, because I saw that the people who came to us to be treated would come to us for their treatment.
Ira, Mama keluar
But-
bisa? Mama tutup.
Could you just they come to us for their treatment, and then they would go to the traditional healer for their spiritual treatment. And that was quite common. So I thought we needed to look at this. And then in 1992, Anatole Breuard wrote this book about his disease. And he said that the hospitals were sterile, impersonal, they didn't relate to him, that medicine neglects the emotional and psychological dimensions of disease. And he called in 1992 for a shift in the way we train our future doctors and nurses with empathy and communication. And of course, this is before we started the quality improvement movement. Now, in 1992, I had been a doctor since 1979. So for 13 years, I've been a doctor, and I had, luckily and fortunately for me, I had some good training in South Africa where we were taught empathy and communication skills, but it wasn't standard. So I think that there's a good history of why we need to humanize healthcare. Another reason is healthcare has been industrialized. And that results in burnouts and people's satisfaction. I refer you to this article from Victor Montori. He's written a number of books on the importance of kindness in healthcare. And really, they sometimes call it the healthcare industry. Well, the industry, you can see there's Charlie Chaplin from Modern Times. And what happens if you have an industry? We have siloed teams. What happens with siloed teams? Very successful if you've only got one disease. But nowadays, if people growing older, they have many diseases. And what we expect them to do is go to a hospital and see different teams across different specialties that are not integrated. So siloed teams means we've got to humanize something. And what happens with this with industrialization? Well, this was studied in the 19th century by the great theorists Durkheim, Weber, and Karl Marx. Karl Marx only didn't do Communist Manifesto, he also studied alienation. But Weber and Durkheim studied alienation. And what does it lead to both in the patients and the doctors and nurses? They feel powerlessness. They find lack of meaning. They don't follow norms. The patients don't follow what we ask them to do, and the doctors don't follow what we ask them to do either. There's cultural estrangement and social isolation. And these lead to estrangement from what they want to do. And in healthcare, it leads to burnout. Now, this is burnout in the United Kingdom. And you can see that up to 60% of all healthcare providers, at different levels, they show in the community, in the hospitals, etc., have experienced burnout. And I'm sure this applies in your region as well. And if you have burnout, unhappy staff lead to unhappy patients and lead to up to 2 to 3 times medical error and harm. So industrialization of healthcare has been very successful because we've had people living longer. That adds more complexity. That adds more burnout because people are estranged. So we have to really think differently. And now we have telemedicine, in which we ask people to speak to us on the iPhone or Galaxy or on the internet, in which there's a lack of the human touch, lack of compassion. And to make it even worse, we've even now got artificial intelligence that people think is going to take over from doctors. No, it's not. It's just another tool that we will be using. But there is the threat that it's going to impact on person-centered care and humanization of care. So there are many, many reasons you can see right now why we have to address this and why this is probably the most important part of healthcare. Because if we don't look at the humanization, not only of the people we call patients, but also of the people we call healthcare workers. We have to make it humanized, so we've got to care for both. And I would argue that we start with our own workforce and we make person-centered care about our workforce as well as person-centered care about the people we call patients. Because it's these two people who come together to create perfect care. And you'll see how as I go along. Now, there any questions? Because if there are questions, Hani can look in the chat and tell me, and I will stop sharing and get to the, and he'll read out the question for me and answer. So comments and questions as we go along.
Not yet, not yet.
Not yet.
Okay.
Now, the next question is, what is the lived experience of the person we call a patient and the person we call a healthcare provider? What do they actually experience? Michael actually said we experience imperfect care indirectly. He said that we get imperfect care. That's the experience, and that is true. And what is this? This is from the Beryl Foundation and Jason Wolf. And you can see they have in the middle, you have patient experience surrounded by the workforce experience, surrounded by the community experience, and then the human experience. Yeah, what is the human experience? Well, it's the environmental factors, and these shape what you're going to do. It's all the interactions at every touch point on the continuum of care. So they're talking about integrated care. It starts not when they come to a hospital, but it starts at home, at every touch point. And then it is the people, the patients, the family members, the care partners, the healthcare providers, the communities that the healthcare organizations serve. And that determines the lived experience of the person right in the center, the person we call a patient. This all depends on all the other experiences. So we have to think about lived experience as not only about what happens to the person we call a patient, but how every other part of the system is working. Because that is what they're going to experience as you test this all out. So what has been the quality response to this challenge over the last 25 years? Now, as you said, I told you I graduated as a doctor in 1979, and the health quality movement started in 2000. So for 21 years, I was working without a quality movement behind me. As a consultant pediatrician, I was involved, not involved in, but I knew there were patient safety issues and quality issues. But what have the quality been since 2000 when it all started? It really started then, although beforehand, of course, we were doing quality. But there's three levels of quality. Quality 1, 2, and 3. And it's a journey. And we've been coming along this journey, and the journey in Quality 1 actually started before 2000, and ISQA is an example. It actually started in 1920 with a man named Codeman, who said, he's an anesthetist, and he said, we need to know what the end result is. What happens to the patient? That's in 1920. And then over the next 80 years, there were many areas and accreditation and regulation started. So quality 1.0 are all of these things: setting standards, evaluating, certification, guidelines. And you can see the two big bodies on the international bodies, ISO and ISQA. So ISO, very good for laboratories and for process. And they just got a management system out now for health management system. And ISQA accredits all these bodies. And I went to the ISQA website and I pulled up all the local ones. I might have missed some of the bodies that are involved in accreditation in the region, but I hope yours is there. And this is the baseline, the foundation of quality improvement. You have to have standards. You have to evaluate against the standards, and you have to certify if necessary, and sometimes you have guidelines for the clinicians, standard operating procedures. And this is the basis of quality improvement, the foundation. But is it enough? No, it's not. Because it doesn't mean that if you have MSQH certification, and then you go for JCI certification as well, it doesn't mean that you're perfect. It means that you pass the certification on the day that they came. And I always say to all the bodies, other hospital or any hospital that says to me, oh, we JCI certificate or HSO or MSQH or whatever, I say, well, do you ever have to prepare for this accreditation cycle? And they say, yes, we have to get ready. I said, then you're not ready ever, because you should be ready all the time. You should never have to prepare, because you should be at the level at all times. So how do we get to that level? We go to step 2, which is quality 2.0. And here are all the theorists from quality 2.0. You see the top, the names you'll know: Deming, profound knowledge; Shewhart, statistical control charts and PDSAs; Duran trilogy. In the middle, you can see Ishikawa, Taguchi. That is how to do, and Shingoi, that's Lean, Six Sigma. And the bottom, Crosby and Gilbraith, management. And then Berwick, who helped bring it into healthcare. And in this one, what we do is we've been doing it for the last 25 years or 30 years. And we're looking at systems theory. How does the system work? Does it provide reliable care? And we manage variation and performance management. And we have various tools. We have diagnostic tools like the Ishikawa and the Pareto and process mapping, and then the improvement tools like Lean Six Sigma and Model for Improvements, etc. But is this enough? This does improve, but it's not enough, because we're still not safe now in 2030. 2026, we're not safe. We're not high quality care, but we're getting there. We're getting better. So now we believe we need to do more. So here's the Duran trilogy. And this is very important, because if you remember when I showed you the very first slide from the WHO, we said you've got to plan for person-centered care. It doesn't just happen. You have to measure it. So here I said the zone of poor quality, I could say poor person-centered care. Then you have your improvement program and you get to your new zone. And this is a SPC chart that you can do. That's the Duran trilogy. And you have to think about systems. How is our system working? And it's very important in person-centered care, because you have to think about the system that you work in, where you work, and how to interact with bigger systems, the variation that happens in the system. So if I was looking at person-centered care, why on some days does it work and others? Is it person-person related? Is it systems related? What do we have to do? You have to understand the beliefs. This is the most important one, the beliefs of people. If they don't believe it's important, it's not going to happen. And then you have to have a theory and method to improve. So this is profound knowledge from Deming. And just to say, this is the foundation of it. You have to do this in order to get high-level care. But what is humanization? Sorry, Vera, could you mute? Could you mute? Thanks, Vera. Anyone who's not talking, please mute. So what is humanization? I'm kind of talked about it earlier, but let's say humanization is about when we get to co-production. And co-production is about giving up power. And giving up power means we have to think totally differently about healthcare. And we have to think very much differently from just doing accreditation, doing improvement work to meet the standards. We have to think differently. And this is co-production of health, and I'm doing some work with Paul Bertelden. Now, he's the leading thinker in this. And it's talking about moving from ownership of disease to ownership of health. Who owns health? Talking about the kinship. And kin's a very interesting word in English. It means the community and family that the person we call a patient lives in, the kin. We talked about integrating care, breaking down the silos and creating value. And what is value? Value is the perfect care, where the person we call a patient gets what they value. And this requires everyone to work together. This is from one of Paul's papers. We need to design, create, develop, and improve the relationships and actions that lead to the health, not the management of disease, but to the health of people. And that's a very different take on managing disease. It's a very different way of saying we want to decrease the number of people who fall, while rather than saying we want to increase the number of people who stand all the time and don't fall. So it's turning things on its head. So just to iterate, we need standards. We need the improved methodology. We need to focus on the new areas that are coming in, AI, digital health, but we need to co-produce solutions. And that's the future, the global future of healthcare. To do this, we came up with a new model called the multidimensional model, and Paul and Chris van Hecht and I wrote this paper in 2001. And we said, these are the domains of quality from the Institute of Medicine. They're a bit old. So we said person-centered care actually surrounds all the care. And we need to add the climate change in there. So we've got eco-friendly care, and including the other 6 domains. So that means that person and kin-centered care surround everything. It's not one of the domains, it's all of the domains. And we gave it some values. We had a few values that there must be kindness, compassion, there must be dignity, respect, integrated holistic care, all founded on partnership and co-production. Leadership, resilience, and transparency were the other values we added. And we call this the multidimensional model because this is, we think, is the future for quality in healthcare, where person-centered care and kin-centered care surrounds everything. So respect and kindness is very important. This is from work by Ballant and Kemplin in the United Kingdom, where they say if you have kinship, relationships, kinships about relationships, that leads to kindness. And you can see this, the word in English is from the same derivative, kin and kinship and kindness, to see the kin. Kindness, if you have kindness, it gets attentiveness. People become attentive. And if you get that, it gets alignment to the context. And that will get trust. And once you've got trust, you can co-produce and humanize. This is called a cycle, that intelligent cycle that gets you around so that this happens. Because if someone's kind to you, you'll go to the next stage. But a very important part of healthcare is having trust. And in many of our communities, there's a lack of trust, particularly after COVID, a lack of trust of healthcare. So respect and kindness is essential. And that will require leadership, and for you to have compassion and kindness, courage to do things differently, respect in relationships, and that's part of the vision which has transparency. And this is from the International Federation of Integrated Care, where they have their own integrated care. And you can see from the 9 pillars that they call it the 9 pillars, they bring it all together with shared visions, population, people as partners, resilient communities, looking at the workforce, digital solutions, and also align the payment systems to allow this to happen. So integrated care is part of humanized care. And I'd urge you to look at this foundation. Hanny's got the slides for you to have a look at. But it also requires safe culture. Sorry, Sarawati.
Sherawati, please.
Okay, mute please if you're not muted. So you also need to have a safe culture, which is just, informed, flexible reporting and learning. So you need a safe culture as well. And finally, you need to have power sharing. And this is we call the ladder for power sharing. And you can see at the bottom is where most healthcare is, doing the 2 patients. Often we move up to engagement and consultation, but the real power is where we do it with people, co-producing and co-designing. So another way of looking at it is like money. Person-centered care is about relationships. It's when you give up power. You have a relationship. It's not a transaction. It's open. It's shared. You pull people in, and it's held by many. It's just like electricity versus currency. An example is shared decision-making, and this is one I developed for maternity care based on Elwyn's work, where on a clinical level, a mother-to-be would, with the midwife or the obstetrician, would co-assess what they want to happen, co-decide what's going to happen, co-design the future, how the birth is going to happen, and co-deliver together. The shared decision-making. This is at a clinical level. And this is what we're talking about, humanization of healthcare as equal partners. And you'll see why it must be equal. And there's a lot of papers coming out now in talking about how you can create these safe spaces where people are able to respect each other and share and able to do this. Now, of course, why I chose maternal health is because that's one of the examples where we medicalize healthcare and we turn something natural, which is childbirth, into a medical condition, which is needed to make it safe in some aspects, but you also need to keep the humanization part. Because the one thing, I'm not a female who's given birth, but mothers will always remember the birth experience that they've had. They always will. And the woman on the call will tell you that is what they remember. And I like this from South Africa, where I come, is humanization is about a sense of belonging. We call it in South Africa Ubuntu. We are one. I am because we are. That's where the clinical team have the sense of belonging, and the person we call a patient has a sense of belonging. In Sweden, and this comes from Annette Nielsen, who's talking to me with Dublin. We're going to present this in Dublin. It's about what matters to you, to the patient, and to the doctor, and coming to agreements what should happen and making it work. You need cooperation, continuity, and access. So working with Chris van Hecht in Belgium, we looked at what does this all mean. It all means that when people come together, a doctor, a nurse, and a patient, a person we call a patient, there's that moment of truth where perfection may or may not happen. And to do that, you have your internal and external environments. You have the values that in the multidimensional model. You have the foundations of the care pathways and the domains of quality, and the values holding it up on the side. And the roof is person-centered care for patients, kin, providers, and professionals. And that all recalls trust, and we call this the house of trust. That's essential. And in Flanders, I'll give a talk on Wednesday to the group in Flanders, where they're implementing this house of trust across the whole of Belgium. They're doing it Belgium, and now it's going to Australia, as well as to Canada, to British Columbia. We're presenting again at ISQA, so I think you want to look at that. And there you can see where there is evaluation at the bottom, the accreditation and government inspection. But in the middle, you can see the teams and the hospitals are self-evaluating what they often call the softer signs. Are we doing the perfect person-centered care? So coming to the end of my talk, this is where Paul and I are working on the latest in quality improvement. We're saying that what's happened is that in the industrialization of healthcare, we've made quality and we made healthcare a product, and healthcare and safety also a product. What is a product? A product is something you buy. But what is a service? Something you buy or something you experience. So this is the kind of observations we're looking at. It's all about listening, observing, acknowledging, and reflecting. So the patient, the person we call a patient, is coming in to see us. They have their story, their feelings, and you have the professional. And they're going to plan together to either get a service or a product. Now, sometimes you want a product, and other times you definitely want a service. And that's all going to work together. So how does it work? Here you can see the different iterations. So we really want to look at the service product when you go from service to product. And the example is if you have a myocardial infarct, you want to get the product of resuscitation, but you want to have the service when they wake you up, and you want your family to have the service from the time you start. If you get a stroke and you come to a hospital, you want the product of early intervention, but you want the service surrounding it as soon as you wake up. And what you need is you have to think what happens. Making the service, and there are many different things, that there are different steps, and there are two makers, the patient person and the doctor nurse person. And it's really important that in the middle is trust and respect, right in the middle, and the knowledge of each other, making a service. Whereas making a product is what we do with Lean and Six Sigma, and often when we do more quality improvement, we're doing projects. So Lean methods are very useful. And we do need to do both. It's not one or the other. So let's look at it again. The professional comes with content. The patient comes with their own content. They come together. What helps? What matters to you? What works? What's going to work for you? What are the roles, tasks, and other collaborations? Sorry, let's get this smaller. What are the steps we have to make to get the product done? And when and how do we move between the two? So this is what the latest thinking we have on developing a service rather than a product. And what are the constraints? Now, the patient has to prepare. So what does the patient bring? This is from a really good article by Vincent Dumas from Montreal. And this is what the patient brings. They bring navigation knowledge, what the system's like. They bring their own medical knowledge. They bring monitoring knowledge. They have relationship knowledge of the community and their cultural knowledge. So the patient comes with a lot of knowledge that we often neglect to look at. So bringing this all together, we need to say the person as a patient has a lot of preparations. What's my story? How will I tell it? What language must I use? Will they listen to me? What are my needs? What really matters to me? What are my feelings? And we, as healthcare providers, must be ready to listen and respond. What support will I have? You can see, what resources do I need? These are all the things that the person as a patient prepares. And we have to activate them to do this. And when that happens, all of these different models I've shown you in the talk come together. Now I'm going to be very personal now and tell you my own lived experience. A lot of you might know what's happened because I gave it at ISQA conference last year, so I thought I'd include it right now. So 2.5 years ago, I was diagnosed with prostate cancer. I had a diagnosis on the phone, but I first had my PSA. It was slightly up. My family doctor said, you need to just check it. And because it was just over normal, you'll get you have an MRI scan. MRI scan comes and it says, well, it's type 1B. The doctors phone me and say, well, this is all on the telephone in December or before Christmas. Says you need to have a biopsy in the new year. So I wait 2 weeks and then have my biopsy. And then 3 weeks later, after the biopsy comes back positive, and I have a PSMA scan, and it tells me I've got stage 4 carcinoma with no symptoms. Very surprising. And then I have to start treatment. I wanted my treatment to be like this, smooth and calm, like a waltz. PSMA. I didn't want chemotherapy, even though I knew it was going to be recommended. I was interested in quality of life, not quantity. That is my interests. And I wanted self-management. They were only interested in staying alive, not in quality. I said, stop the music. Let's start again. So I said to the oncologist, look, I want quality of life. That's what matters to me. Let's start again. And we started again. And I think that I said, this is what I want. And I said, this is what you must do. Ask what matters to you.
Come fly with me, let's fly away. If you can use some exotic booze, there's a bar in
We wanted to fly away together. And that's what we've done. So from my own lived experience, I've learned that if we listen to the people we call patients, we can make a difference. So there are a number of take-home messages. Firstly, we must understand when a service and a product, they are different. And in industrialization of health, we created health as a product, managing disease. To sort this out, we have to rebring compassion, kindness, and empathy back into healthcare. Message number 2. To do this, co-production and building trust is the future, and we have to do this. And we have to learn the dance moves of our people we call patients as healthcare providers. And of course, as you know, they all have different dance moves. We have to know them all. They'll only have one, but we have to say, what matters to you? That's the dance move. What matters to you? What are you looking for? What is perfection for you? Then you won't be disappointed if someone asks you that. Now, just an advert as I end. This is the new website that we've just launched, www.coproducehealth.com. If you go to that website, you'll see these are the founders. There's Paul, Julie Johnson, Christian van Plessen, and there I'm at the back, and a few patients. And then for those who want to apply for this fellowship, the Kearney Global Fellowship, which I run, we have some from the region. Closing dates the 15th of July. There's the link up top. Take it quickly. Take your photo of it if you want to come. Otherwise, thank you very much for listening to me, and we can have some questions.
Thank you very much. It's very, 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 very great how you talk. And I think everybody is astonished. Maybe you can share your slides in the...
Yeah, I will share the slides. Yeah, Hanny, you've got the slides. There's no difference. I just made some things bigger, but I'll send them to you again.
Yeah, okay. Okay, so we send the later the first one, so people will have them. Somebody wants to ask. Maybe I will start. Peter, what's the difference to you about people-centered care and person-centered care? Is it any difference or is it the same?
The difference between people and person is the same. People and person is the same.
Same, yeah.
Person is just the individual, people is just the plural. The difference is between patient-centered care and person-centered care.
Oh, patient-centered care.
And that's the big difference. So, and then now we're on human-centered care, which is even the next level. So if you go to Beryl Foundation, they're human-centered care. They're saying it's even further. I now talk about, if you've seen in the talk, I was speaking about the people we call patients. Not patients, the people who we call patients. Meet the people who we call doctor or nurse. And when two people meet, they have a relationship, not a transaction. They have a relationship. Now, I can tell you my own experience. Whenever I go to the hospital as a patient, I make sure I'm kind to everyone I meet. What happens then? I get kindness back from every healthcare provider, from the porter to the receptionist to the one who takes my blood. If I'm kind to them, they are kind to me.
Yes.
Can you see it works both ways? So the patients, if they're kind, but if we're unkind to the patients, they can never be kind to us.
Mm.
So kindness is the foundation of it, and it happens when you're talking about relationships. It's
Yes.
all about taking it back to the individual. Look, we need all the technical stuff. We need the accreditation. We need the regulation. We need the improvement. But it's all about the people. And I now talk to people. This is a very important question, honey. I say, we need to put the person back into the patient.
Mm.
Because as soon as you become a patient, you lose power.
Mm.
You become an individual. You're a disease.
Mm.
So here I see some questions. So yeah, okay.
Yes, from Jan Asgan.
Okay. How do I where it is medically unsafe or not recommended? Oh, you should always be safe. I mean, the thing is that when a patient insists on a treatment, you have to step back and engage them as a person and find why. Now, I used to have to deal with parents with children with very complex conditions, and they'd come in for a treatment, or they'd say, I want an MRI. And I'd say, why? What is your reasons? And once you understand their why, you can often come to a solution. So it's to try and diffuse it early on. And I actually, I'm going to answer in the second question. It's never too much to be kind. It doesn't take a lot to be kind. It doesn't add to your 5 minutes or your 10-minute consultation to say, how are you today? How are you feeling? What matters to you? It doesn't take long to say, to find out. For example, what I used to do, one of the things is for the children, I always knew who their football team was or what they were interested in. I'd make sure I'd find that out. So my opening statement, if they were mad about football, I would say, what do you think of the game on Saturday? Straight away engaging with the child. Not how's your disease today, but how did Barcelona play or how did Arsenal play on Saturday? What do you think of the game? Straight away, we are on a relationship, not on a transaction. Can you see? So then it doesn't take time. So in answer to that question is that it never takes too much. This is from J.M. Barrie. It never takes too much time to be kind.
Yes.
Never does. So you always got to think, what would you like? And the little things you do, it's the little, I'll give you another thing. There's a movement called the Mango Movement. I didn't show it today because I didn't have time, from Chris van Hecht. And it's Mango Moments. And it's really, if you can think about that, it's very important. And if I find it while I'm answering a question, I will show you the video. Do we have time, Henry?
Yes, we still have.
We still have time.
Yeah.
Then I can show you the Mango Moment video if I've got it here.
Is it called spiritualization of care?
Yeah, and let me okay, the two things I've got it here ready to show you. So I want to answer this question. Okay, so you can exit there. Okay, okay. So can I just share my screen again?
Yes, sure.
Okay, and then I'm going to show that video. So share sound, share. Okay. This one, slideshow. Oh, sorry. I've got to just go to, sorry, it says from, I've jumped to the start of the slideshow. It's that one, the current slide. Tell me if you can hear the sound when it starts.
Dus als je hier ligt, wat zie je dan vanuit je bed?
Het plafond.
En al die machines.
Ja. Dat alles wordt vanavond te gek voor.
Ja. Sommige mensen die op intensieve liggen, die vertellen ook dat ze dan heel akelige dromen hebben of akelige dingen zien. Was dat bij jou ook zo?
Ja. Ik had iedere dag van een familie bij me zitten. Iedere dag iemand anders van de familie bij me zitten. Van mensen die al heel lang dood waren.
Ja.
Ja. Dat klopt. En dan keek ik en het waren toch dat
Ja.
En dan keek ik weer gewoon. Dan zag ik die er wel zitten.
En dat was angstig, dat waren...
Angstig.
Ja.
Ja.
Geen fijne beelden.
Nee. Ik heb nog geen fijne beelden leren gehad.
Nee.
Nee. Qua dromen, nee.
Geen mooie dromen.
Nee.
En die bange dromen, zijn die nu weg?
Die mensen zijn geminderd. Ze zijn niet weg, maar ze zijn wel geminderd. Dat is een normale goed tekenen.
Ja.
Zeggen ze. Gisteren bijvoorbeeld was er gevraagd voor een spuitje.
Een spuitje? Wat bedoel je?
Altijd een zin.
Is het echt waar? Zag je het niet meer zitten?
Want hoe ga ik eruit komen? Ja, nooit meer dezelfde zijn.
En hoe kijk je er vandaag tegenaan?
Is het weer anders?
Ja?
Kijk het er naar uit voor een beetje kunnen te eten. Dan krijg ik soep en patatjes voor de eerste keer.
Voor de eerste keer. Dus dat is toch ook een belangrijk moment.
Zeker. Ja.
Je hebt dus niks gegeten in al die tijd.
Beetje gezonde voeding voor de
Ja.
rest niks. Ik kreeg niks.
Ja. Ik kan me dat bijna niet voorstellen. Wij proeven heel de tijd, maar je hebt lang niks meer geproefd. Er zijn er wel zo dingen waar je naar verlangt. Wat wil je graag nog eens proeven?
En een mango.
Ja.
En een mango.
En nog iets?
Eigenlijk alles, maar dat heeft mijn voorkeur.
En een mango.
Lekker.
Ja. Dus vandaag zet jij grote stappen, toch?
Dat ik eigenlijk ook naar vraag.
Ja.
Je wilt vooruit, je wilt
Tuurlijk.
naar huis.
Je wilt naar huis.
Ik wil naar huis. Jazeker.
Goedemorgen. Dag Vivian. Kijk. Surprise. En ook nog een mango drankje. Heb je nog altijd zin in mango? Ja, ik heb dus mango bij, omdat Vivian daar zo naar verlangde.
Ja, Vivian.
Maar mag ik haar een stukje mango geven?
Ja, dat kan je kwijt.
is een goeie. Dat is zo zalig dat je zo terug van kleine dingen kunt genieten. Hè.
Heb je het gesmaakt?
Gesmaakt. Lekker. Lekker. Ja, zal ik nooit vergeten.
Nee.
Nee, zal ik nooit vergeten.
I always find,
Very good.
yeah, I always find that movie very moving because that was not a healthcare worker, that was a journalist. And now that's a movement called Mango Moments. We
Yeah,
give small acts of kindness to the answers to the questions. And it never takes too much to be kind. Now, we've got two hands up.
Yes.
Some questions. So,
Nico
and Sutoto. Nico.
Thank you, Dr. Peter. Very amazing, comprehensive presentation. I think it's beyond a perfect presentation. It's beyond a perfect presentation. So you explain your insight as humanized, personalized, culturally based care. Now,
yeah,
we do NPC shared decision making, shared values, shared vision. So the balance between the professional and patients with these shared values. Can you discuss about this? Because if you overshoot, then you just make a depersonalization care.
Okay. So the important thing is that we have what we have to do, standardized care.
Okay.
And when you personalize care, it must be within the standardized care. So the idea is that you must manage the care. So the shared decision making is I'll give you another example, because when I used to have children with epilepsy, I would say to parents, what's your attitude to risk? Where are you on the risk register for drug reactions, because they all have that, or the risk of another seizure?
Yeah.
Because putting your child on the anti-epileptic has a risk, and keeping them off the so which is I want to understand what you find the most scary, another seizure or risk. But I also always say, at some time I will have to say, this is what you should do, but we get to that decision together. And it's really so this means we have to change the way we think from what we tell people what we should do to them, rather than saying, these are the things, the options that we have, and these are the things we can. And people say it takes longer. But actually, once you know how to do it, once you've been taught how to do it, it's very quick. It's just like a dance. Once you understand the steps, you learn to dance together very quickly. Will you step on each other's toes? Yes, at times. But will you learn? Yeah. And it's really a change in the culture of thinking.
Yeah.
So, Nico, I think that shared decision-making, there's a lot on it, is that you can't just tell people to share decision-making. You have to teach them how to do it. Both parties, the people we call patients and the people we call doctors and nurses.
So one thing is based on individual professional competence to dig the culturally, their habits, etc. Okay.
Yeah. Well, the problem is that historically, healthcare has been, in time immemorial, it's where you go to the doctor and they tell you what to do. And then you decide whether you're going to do it, yes or no. But the evidence shows that if you go to your doctor and the doctor discusses with you in a shared decision way what you should do, you end up doing it even if you didn't want to do it in the first place, because you become part of the decision making.
Okay.
So if you're part of the decision making, you're likely, and that's why when we talk, they say the patient didn't comply with the medication. Well, the patient wasn't asked whether they wanted to take it in the first place. Can you see?
Yeah.
So it changes that. It's all about power. It's all about power and how we use it. And it's a really new way of thinking things. I have to move to Sutoto. Thanks, Nico.
Thank you, Peter.
Sutoto, your hand's up. And you're muted. Sutoto, you're
Pak
muted.
Toto, dipersilakan di-unmute dulu.
Mas,
Belum, masih mute, Pak Toto. Ya, oke. Oke.
Okay, any
Dr.
other questions
Peter
we've
Rahman.
got here?
Dr. Peter Rahman, thank you for your inspiring presentation. I'm deeply impressed by how you connect quality improvement, patient safety, humanization, and co-production into a practical framework that challenges us to rethink healthcare from the patient perspective rather than the system perspective.
Yeah.
You mentioned that a healthcare service can be technically excellent, safe, evidence-based, and compliant with standard, yet still fail to be meaningful to the patient. My question is, why do you think healthcare services that are technically good and clinically successful are not always perceived as meaningful by patient? And in your experience, what are the most important strategies that healthcare leader and frontline professional should implement to bridge the gap between technical excellence and what truly matter to patient in terms of quality of life, dignity, and life experience? Thank you very much, Dr. Ram.
That's a great question. So I think this is all about the service versus product. So I think that's very important that we look at it. And that's what Chris is doing in Holland, in Belgium, is looking at the Flaker model, is really looking at how can we get this house of trust that I showed you. And they are really trying to think differently on how this happens. So it's really trying to say, how can we get hospitals to go beyond the product? You were talking about, Sutoto, about product, the product of technical excellence, and turn it into the service of experience. So, okay, I like to compare to many different things. Like, you can go to a restaurant that has got 3 stars from Michelin, that has got the highest quality food, the most technically based food, and have a terrible experience and person-centered care. The waiters can be rude. You wait for your food. It tastes wonderful, but no one asks what matters to you and how you want the experience. We're not restaurants. But I always say that a hospital is a hotel for sick people who don't want to be in the hotel. And if you're in a hotel, when I go to hotels, I'm always watching this to see what's this thing about person experience. I stay a lot in a Marriott hotels, and they're all about person experience. From the minute you walk in, it's about person experience. Every member of staff is there for your person experience. Then I asked them, what's this all about, this person experience? But I even videotaped with a service manager to ask him what it is. And he says, well, we are here for you. And I said, how do you get this done? Well, it says, well, the management are there for the workers. The managers are meant to look after the workers to ensure they can deliver person-centered care to the customer. Now, in healthcare, we often are in healthcare to look after disease, not people. We are in the people business, not the patient business, the people business. We have to put the people back into healthcare. So it's really rethinking about how we look after our healthcare workers, giving them a sense of belonging, making them feel psychologically safe. And then people say to me, we don't have enough resources. I say, even if you don't have enough resources, I've worked with teams in Africa with very little resources, but they work as a sense of belonging, as a team together, sense of purpose, and person-centered care is part of what they do. And it's quite interesting in a place like Mozambique, they talk only about humanization of care in Portuguese. They don't talk about persons, they talk about the humanization of care. So I think it is possible, but I find there's a lot of organizations that are accredited by the local accreditation body and JCI or HSO, and still they're not there. And that is because they're treating it all as a product rather than as a service. So you need to watch the space. We'll be publishing soon on our latest ideas about service and products. Thanks a lot for that great question. Do we have to end soon, I guess? Are you on mute, honey?
There is some question from Michael Sinnott from Australia. Maybe.
Yeah, so he's been very interesting question he had there, Michael. I've just got to go find it again. Okay, Clara was the first question.
Yeah, Clara.
Then around the world civilization. Yes, I agreed. Michael, what percentage of change comes from healthcare workers? Well, it's hard to say because I think both sides have to be re-educated in a way that we can make a difference, Michael. I know in Australia you call the person we call them consumers because they're buying a product, but it's really about a service. We have to start the education in both areas, and this is where I think the patient movements, World Patients Alliance, they all need to start thinking of how can we re-educate people we call patients about what they need to do and how they can interact. At the same time, definitely, we have to change the way doctors think about patients, think about how they diagnose, how they give information, how we support. And this has to change because healthcare has changed from treating individual disease to treating chronic morbidities. And I know I'm old enough to have a condition that causes different specialties. And people now who are getting older need to be treated with compassion, families need to be involved, and we need to change the way we think. So the healthcare has to really change. So if you had a percentage, I guess it's more on the healthcare side. Mainly because the patients are willing to do this, and the people giving up power is more difficult than getting power, what I can say. So it's more hard work for the patients than for the doctors and nurses. More hard work for the patients to get it, and that means the doctors and nurses and other clinics have to work harder to give it away. So I'd say it's about 60-40, maybe, but that's a good guess. Then there's from Rena Grace, basically about how as maintaining the burnout. Really, we've got to every day. It's a gain. I say for the burnout, every day ask your clinical staff how they're feeling. At the end of the day, what was your day like? Little things. Small acts of kindness, small acts of kindness. We'll deal with that. But I think the rest are comments. And the last one, Michael asked me about the treatment for the. I'm actually, to tell you the truth, I'm on the most sophisticated treatment you can get on hormone therapy. It has its own set of complications, but it gives me a quality of life that is better than if I had chemotherapy. And I share my story openly. I believe it's important for people like me in my position to share my story. And I've told the story across the world. And this is first time I've done it live on a meeting like this to over 200 people. But I've done it to 900 people in person in Madrid, to 600 in Cartagena, and I did it at the ISCRA conference last year. This message is that we need to start talking about what we can do, because if I can manage to get it right by getting people to dance with me, then maybe we can change the way we dance with each other. But I really want to thank you, because we've gone on for an hour and a half. I guess it's really done. And then the material is there. It is the only change in the material is that one and the only changes is that I changed the fonts of some things. But I want to just ask you to attend maybe the World Patient Safety event on Thursday. Just go to my LinkedIn, and there you'll see a post of the details. Will be coming out again tomorrow, a post on next week's session on World Patient Safety Day. Because it's very important that you think about how you engage patients. So thank you very much for having me today. And I like the last thing: medicine treats disease, kindness heals the soul. So thank you, C. Lei.
Yeah,
You
I
have
just
summarized my whole talk for me. Thank you very much.
very much. Yeah.
Okay, it's
Okay,
getting
we'll do keep in touch, Prof. Thank you so much.
Yeah,
it's
so
getting very
anyone
late.
can contact me on LinkedIn. If you join me on LinkedIn, you can send me messages. I will respond to you if you want questions, and hopefully one day I'll see you in person. But
Oh,
hopefully I'll see you in
definitely.
Dublin. Yeah, hopefully I'll see you
Definitely.
in Dublin. Thanks very
Thank you,
much.
Prof.
Okay, thank you for all the questions. From Camille, it's not yet answered, but I think it's the same. It's getting very late, and we are going to close this session with a prayer to God for the miracle to Peter Lachman. Dear God, we lift up Professor Peter Lachman to you today. You know the man behind the work, his dedication, his kindness, and his heart for making hospitals safer for all. If it is your will, please touch him with your healings. Send miracles where medicine reaches its limits, strengthens his body, calms his worries, and surround him with peace. May he feel how deeply he is loved and appreciated by people all over the world whose life he has touched. Let him recover fully so he can continue to be a light for the patient's safety and for humanity. In your mercy, grant him health, strength, and many more years to share his wisdom. Amen. Amen.
Thank you. Thank you.
Thank you. We hope everybody here, we hope for your for miracles to come to you.
Healthy.
And God is
Yes.
very merciful. Okay.
Thank
Dr. Stato mau tutup? Do you want to close? Or Dr. Nico?
Dr. Hani aja.
Yeah, okay. Yeah, I think with the prayer, we close the session. It's very superb. We put the presentation that you sent me already in the chat. Please download the in the chat. We hope everything best to you. God be with you. Thank you very much, Peter, and let's meet in Dublin. Thank you very much.
Thank you very much.
Thank you. Thank you.
Maybe you can
Thank you.
open so we can make photo together.
Photo, yes.
You need to go off spotlight.
Yeah. No, spotlight, close the spotlight so we can make photo together, all of us.
Yang mau bilang sudah apa tanggal 13.
Yeah, okay.
Ini loops kita.
Thank you, Dr. Peter.
Okay, put your camera on, your video on, please. Okay.
Yeah.
Siapa yang motret? Yang motret? Barkah, tolong foto. Okay. First slide. 9 pages. Second page. Third page. Fourth page. Tolong dibuka videonya. Open the video. Ya. Sixth page. Seventh page. 8. Okay, finish.
Okay.
Thank you very much for
Thank you.
everybody, especially for the foreign participants.
Okay.
It's we will have next month. You have the list in the chat. Who's going to talk next month? It will be Barkah. Who's the Richard Greenhill. Richard Greenhill from USA, writing PCC issues in international journals. He's the editor of the ISQA journal. Yeah. Thank you very much.
Thank you.
Thank you, Dr. Peter Rahman.
Thank you, everyone.
Thank you very much.